Good afternoon, Dr. Frere. Would you like to wait the 1 minute till 2 o'clock?
Yes, I guess so.
Okay. Good afternoon, Dr. Frere. It's 2 o'clock. Would you like to get started?
Yes, thanks, Kim.
Wonderful. Good afternoon, everyone. Thank you for joining the Los Angeles County Department of Public Health today, July 21st, for a media briefing. Today, we have the Director of Public Health, Dr. Barbara Frere, presenting. Dr. Frere will then take your questions. As a reminder, to ask a question, please use the hand icon, or you may chat me, the host. When you're ready, Dr. Frere.
Yeah, thanks so much, and good afternoon. Thanks, everyone, for joining us. I'll give the COVID-19 status update for LA County and then provide some information on the importance of slowing down transmission. Cases, hospitalizations, and test positivity remain elevated. We can take the first slide. Today, we're reporting 8,691 new cases, with the average number of cases reported over the last week at about 6,700 new cases a day. While today's numbers are very high, reported cases this past week did level off, and we'll be monitoring closely to see if the trend is going to continue. As a reminder, all case numbers are an undercount since they don't include positive results from over-the-counter tests. The 7-day average test positivity rate does remain high, as you could see, at about 16%. Statewide, the positivity rate is also 16%, and nationwide, it's 17.5%. LA County is also experiencing continued increases in the number of COVID positive patients admitted to the 92 hospitals in LA County over the past week, from 1,200 last Thursday to 1,329 today. Among those hospitalized who are infected with COVID, about 42% are hospitalized with COVID-associated illness, 11% are in an ICU, and 5% are on a ventilator. And I'll go into more detail on hospitalization data in a couple of minutes. Daily deaths remained relatively stable this past week, although we are averaging now 13 deaths per day. As a reminder, since deaths do lag behind cases and hospitalizations, slowing viral transmission will result in lower hospitalization and death rates in a few weeks. Next slide. If we look at the data since March, we can see clearly the increases starting in late April and May in cases and hospital admissions, and the much smaller increase that we saw a little later on in deaths. The most recent increases are likely fueled by the increasing spread of the immune-evading BA.5 subvariant. The 7-day average number of cases reported per day, as shown by the green line, has been very high, higher than during the Delta surge from last year's sort of summer. And as I mentioned earlier, you can see here this sign of plateauing cases the past week. We do hope this continues. I do want to note, however, that over the past 2 months, we have seen some small dips that were then followed by additional increases. So it does make sense for us to continue to be cautious given the relatively high number of cases we see. Daily hospital admissions, that's that orange line, may also be leveling off a bit, and I'll talk in more detail about hospitalized cases in the coming slides. Daily deaths, the blue line, increased, as you can see, slightly this past month. We were really averaging about 5 daily deaths 1 month ago, and now, as I've noted, and as you can see here, we're at about 13 deaths a day. Our thoughts and wishes for peace are with the families and friends that are mourning their loss. Next slide. Throughout the pandemic, those infected with the virus have experienced differing symptoms and levels of illness severity, ranging from completely asymptomatic infections to severe disease and, most tragically, death. Over time, we've seen a shift in the number of infected individuals requiring care in our hospitals and the number of infected individuals that pass away. This is driven in large part by the protections that are offered by vaccination and prior infection, and by the increased availability of effective therapeutics. The shift in the impact of the virus on disease severity has been measured by calculating the percentage of people with a positive test result who go on to require hospitalization, and also by looking at hospitalization rates over time. As those infected are less likely now to require hospital care, it's important to separate out those individuals in the hospital with incidental infections. They need hospital care for reasons other than the treatment for their COVID infection. But they are obviously infected, and we should separate those folks from those who are in the hospital because they need care for COVID-related illness. This is why for the past few months, we've been reporting on the number of what we call incidental hospitalizations. Although these cases do place additional strain on hospitals because any COVID-infected person requires the hospital to take additional safety measures, these hospitalizations are unlikely to reflect patients with severe COVID-related illness. Today, we're sharing a few slides that present information only on those patients determined to have COVID-associated illness. This includes patients who at discharge have the following: a positive test, plus pneumonia or acute respiratory distress or an acute cardiopulmonary diagnosis. On this slide, you can see what percentage of hospitalized cases had COVID-associated illness each month starting in January. The gold line shows the percentage of all hospitalizations for people infected with the virus. The blue line shows that percentage for the ICU admissions, and the red line shows the percentage for people who were intubated. As you can see, since January, the percentage of COVID-positive patients being hospitalized with COVID-associated illness has decreased from 58% in January, that was during the height of the winter surge, to 43% in June. However, among infected patients that needed ICU care, the percentage of those with COVID-associated illness in the ICU has remained a bit more stable. It was 85% in January, and it's 71% in June. Finally, among infected patients that were intubated, the vast majority were patients with COVID-associated illness, 92% in January, that declined slightly to 86% in June. The next several slides, we'll go ahead and look at hospitalization data only for those who are hospitalized for COVID-associated illness. We'll go on to the next slide. COVID has disproportionately affected some communities more than others. One community that has been hit particularly hard are older residents. On this slide, we look at those hospitalized with COVID-associated illness in different age groups from March through June of this year. One note is that the data in this slide is limited to only the first COVID-associated hospitalization per case. So these rates likely underrepresent the true rates. As anticipated, those 80 and over have been hospitalized for COVID-associated illness at a higher rate than other age groups throughout the pandemic. Sadly, with very high rates of transmission, hospital admission rates have dramatically increased for older adults. That's that red line. As of June 30th, the rate of hospital admissions with COVID-associated illness for people aged 80 and over was 29 times higher than it was for those aged 30 to 49. This is in sharp contrast to April, when the differences in admission rates was much less significant. When people pass along misinformation that the current COVID surge is not affecting or hurting anyone, these are the people they are dismissing, our elders. This is because COVID-19 continues to be more worrisome for those who are most likely to experience severe illness if they get infected. Next slide. Black and brown people have also experienced disproportionality throughout the pandemic. And similar to what we have reported during previous surges, when we look at hospital admission rates for those just with COVID-associated illness by race and ethnicity from March into the end of June, we can see that the hospitalization rate for Black residents increased more pronouncedly than for all other race groups, particularly as we go through the surge. As of June 30th, the hospitalization rate for Black residents was 3.3 times higher than it is for Asian residents and almost 2 times higher than for white residents. And recently, as you can see, we've started to see steeper increases among Latino and Latina residents. Next slide. As we recently reported, residents living in communities with lower incomes, higher rates of poverty, are also much more likely to be hospitalized than those living in wealthier communities. And while individuals living in the highest poverty areas have consistently had higher hospitalization rates than individuals living in the wealthiest areas, the gap, as you can see here, has grown recently during the surge. As the current surge has worsened, by the end of June, those living in communities with higher poverty were over 2 times more likely to be hospitalized for COVID than those living in areas where in areas where there was less poverty. That's the red line. Furthermore, hospital admission rates for COVID are rising faster in communities where people are living with high rates of poverty than in wealthier communities. Hospital admission rates for the lowest income communities have increased over 350% in the past 2 months, compared to an increase of about 178% in the highest income communities over the same time period. While there are many factors contributing to the disproportionality seen by race and ethnicity and area poverty, surges in cases disproportionately hurt those most vulnerable because they either have increased exposures, they have more serious underlying health conditions and compromised health status, they're older, and they have less access to health affirming resources. If we care about eliminating these gaps in outcomes by race and ethnicity and by poverty levels, we will need to reduce transmission rates during surges, which, as we have seen time and time again, hurt some residents more than others. Next slide. We continue to track the impact of the pandemic on LA County using the CDC's COVID-19 community levels framework, which CDC created as a measure of the strain on our overall healthcare system. The community levels framework utilizes 1 case rate metric and 2 hospital-related metrics. Last week, LA County moved from the medium to high COVID community level, and we remain in high this week. The first metric is the 7-day case rate, which currently skyrocketed to 481 cases per week per 100,000 people. This is the highest our case rate has been since CDC first started using the community levels framework back in March. The first of 2 hospital metrics in the 7-day total of new hospital admissions is the total of new hospital admissions per 100,000. LA County is at 11.4 admissions per 100,000 people. The second hospital metric in the CDC community levels framework is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. Currently, 7.1% of beds are occupied by COVID patients in LA County. This number, it can be affected by both the number of patients with COVID in the hospitals and also by the number of staff beds in the hospital. Having staff out sick due to COVID and for other reasons can cause that number of staff beds available in a hospital to temporarily decrease, which would affect this metric as well. As I've mentioned in past briefings, if we remain in the high COVID-19 community level for 2 consecutive weeks, that is through July 28th, we will implement universal indoor masking on July 29th to help slow the rate of transmission and protect those most vulnerable. Of all the tools we have used in this pandemic to counter the spread of COVID, indoor masking is one of the simplest and turns out to be very effective tools that we have that can counter rapid spread of the virus. Next slide. Our early alert signals also continue to indicate increased risk across the county. As you'll see, the current surge is disrupting work sites and causing increased outbreaks among our most vulnerable. This is especially true in our nursing homes and among people experiencing homelessness. Currently, all but one of the early alert metrics we're tracking convey medium or high concern. We have high concern for 4 signals: the percent of new variants of concern with BA.4 and BA.5 subvariants. Now it accounts for 72% of specimens. The 7-day case rate in areas with higher poverty, that increased from last week at 272 to 351 new cases per 100,000 people. The number of outbreaks at skilled nursing facilities and the number of clusters at work sites. Emergency department encounters that are COVID related remain at medium concern, having risen to about 10%. And the number of outbreaks in settings serving people experiencing homelessness also remains at medium concern. And although none of the four wastewater systems experienced a recent doubling in viral load, I'm going to show you in a minute that they still reflect a high level of viral transmission. I'm going to go into several of these signals in detail over the next few slides. So take the next slide. The Omicron variant continues to account for 100% of sequenced specimens. The BA.5 and BA.4 subvariants of Omicron, as you could see in the red sections at the top of each bar on the right, continue to be our highest concern because both have an ability to evade prior immunity for transmission and therefore can reinfect people who were infected with other Omicron subvariants. In the week that ended July 2nd, BA.4 and BA.5 combined accounted for 72% of all specimens sequenced. This is an 82% increase compared to just 2 weeks ago. BA.5 is a dominant variant. It comprises about 78% of all sequenced specimens. In comparison, BA.2.12.1, which used to dominate just a few months ago, a couple of months ago, only accounted for about 24% of our sequenced specimens. The CDC estimates that across the country, as of the week that ended July 16th, the BA.5 subvariant accounted for 78% of specimens. This is a jump from 55%, again, seen 2 weeks prior. We should note that new sublineage of Omicron that's called BA.2.75, which has been spreading primarily in India, and which also has the ability to cause reinfections and is very transmissible, has increased just slightly in the past week in the United States. Hopefully, it'll not emerge as a full concern. So far, there have been 17 cases detected in the States and 5 in California, with 1 case in LA County that we reported last week. We'll continue to monitor this new sublineage as well as all the other variants and subvariants that are circulating. The ability of new subvariants like BA.5 and BA.4 to cause reinfections and to evade some prior immunity is driving this rapid spread, the many outbreaks, and the increases in hospitalizations. However, we do all know how to blunt the spread of any COVID variant to reduce the threat to health for all of us, including the most vulnerable. And we also know that taking collective action is still important. As the WHO, the CDC, and the White House all recommend indoor masking for everyone when there is this much transmission, we here in LA County would remind people that this is a sensible strategy for us to use. Next slide. We now have data from all 4 wastewater systems again that I can share today. This includes the Hyperion Water Reclamation Plant, which serves a large area in the city of LA. That's shown on the upper left. The Joint Water Pollution Control Plant, which serves the southern and eastern portions of the county. That's shown on the upper right. The Lancaster Water Reclamation Plant, which serves some areas in Lancaster and Palmdale. That's the lower left. And the Tapia Water Reclamation Facility, which serves Calabasas and some of the surrounding areas that you can see on the lower right. For each plant, the white trend line shows the 10-day rolling average for viral concentration between late May and mid-July of this year. We can compare the trends between the wastewater treatment plants, but we cannot compare the absolute viral load numbers because of the way in which viral load is measured ends up being different across each of these wastewater plants. But you can see for all 4 systems, there's been an overall gradual increase in viral loads across this time period. We may be seeing a plateauing or even a slight decrease in the plants that are serving western portions of the county, while we're looking at some increases that may be continuing in those areas near Lancaster and the southeastern portions of the county. None of these plants had a doubling of viral load within the last 2 weeks. Next slide. Surging cases in the community continue to have an impact on those living in our nursing homes and those experiencing homelessness. The purple line on this slide shows the trend for outbreaks in skilled nursing facilities. The green line is the trend in settings for people experiencing homelessness, and we're looking back since April. The bottom dashed line shows the threshold for passing from low to medium concern, and the upper dash yellow line shows the threshold between medium and high concern. Since the beginning of June, the weekly number of outbreaks in skilled nursing facilities has repeatedly signaled high concern and continues to do so now, although we do have some slight decline there. 33 outbreaks, newly opened outbreaks this past week. Outbreaks in the settings for people experiencing homelessness also, as you can see, have been increasing, although we stayed in the same level of medium concern since mid-May. There were recently 19 new outbreaks in settings for people experiencing homelessness this past week, and that, as you can see, is an increase. Skilled nursing facilities continue to provide enhanced protections to residents and staff, as do facilities serving people experiencing homelessness. Lots of effort is being made to prevent outbreaks and to keep those that live there as safe as possible. But as we tolerate these high community transmission levels, the resulting spread does create a lot more risk, as you see for these two groups in particular. Next slide. Work sites also continue to be places where significant transmission is occurring. And you can see clearly here it aligns with high transmission in the community. The pink line shows the trend for the number of case clusters at work sites reported per week since the beginning of April. There's been a sustained increase in worksite clusters, with 429 reported this past week, 47% increase this past month, and it's also obviously a signal of high concern since, I think, the beginning of July. Spread at the workplace is both fueled by and contributes to high spread in the community. Infected workers transmit at the workplace to other workers, who then can take the infections back home to their homes, where there can be more spread. That then makes it easy for the virus to spread throughout the community. Next slide. At this point in the pandemic, it's not uncommon to hear dismissive statements about our high levels of transmission. However, given the uncertainty of the trajectory of the pandemic, I want to share a few thoughts on why it's worth taking practical, common sense steps to slow the spread. First, as we're all experiencing, when viral transmission is this high, there is, as we noted earlier, a lot more disruption at work sites and in our homes. While some experience a very mild illness, many do not. And we see this in the doubling of emergency department visits for COVID. We also see this in staffing shortages at work sites, including our healthcare facilities. And we see this in outbreaks at work sites that are both expensive because there are costs with covering shifts, and they're anxiety provoking for the workplace, for workers at the workplace. Households with infected members also suffer disruptions. For some, this includes lost wages, difficulties isolating, and needing help caring for children. High community transmission also leads to preventable and avoidable deaths, primarily among those most vulnerable. Nearly 4,500 people have already died from COVID this year. If we can slow down transmission, we have a good chance at preventing some people from dying in the upcoming months. You don't get sick and pass away if you don't get infected. There are also some issues we should be concerned about. For starters, while there is still the need for additional information, it is clear that many individuals infected with COVID have experienced long COVID. And with big increases in cases, there are likely to be more people reporting illness symptoms weeks after initial infection. The most common symptoms reported for long COVID are fatigue and exercise intolerance. However, breathing problems, brain fog, prolonged loss of taste and smell, and even sudden hair loss have occurred for some. The symptoms are variable, and they may last or reappear over time. This variability obviously has made it harder to systematically track and study long COVID. And because of this, the estimates on how many experience long COVID are widely variable. A recently published meta-analysis of combining many different studies from 2020 and 2021 estimated that on average around the world, about 37% of people with COVID still had some symptoms 1 month later. A study by researchers at USC that was published earlier this month found that 23% of those they studied still had some symptoms 12 weeks after they began developing symptoms, and that long COVID appeared more likely to occur in those individuals that were obese or had experienced sore throat, headache, or hair loss during their initial illness. Another study published this year by German researchers followed 96 cases of people with COVID in 2020 and found that a year later, only 23% were completely free of symptoms. And a survey by CDC last month estimated that nearly 20% of American adults who have had COVID-19 are currently experiencing long COVID symptoms that have lasted 3 or more months after they got sick. Taken together, these studies paint a sobering portrait of the long-term impact of COVID illness, and they help explain why we need to be honest and note that for a significant number of people, this pandemic continues to pose a very real threat. Next slide. There are also recent studies that have raised an additional concern on the increased risks to health created by repeated infections of COVID. Given the increased ability of BA.5 to evade prior immunity, many people who had COVID earlier in the pandemic or even earlier this year are getting infected again. A large study recently reviewed medical records of nearly 300,000 veterans with COVID, spanning much of 2020 and 2021. The majority of people in the study were white men with the average age in their early 60s. The study found that at 6 months after infection, those who had been infected more than once had 2 times higher risk of death, 3 times higher risk of needing hospital care, and 2.5 times higher risk of developing heart or lung disease or problems with blood vessels and blood clotting when compared to those who were infected just once. They also saw that those with repeat infections had a higher risk of gastrointestinal, kidney, mental health, muscular, skeletal, and neurologic disorders, as well as diabetes. Moreover, the risk of developing a long-term health problem increased further with each reinfection. The risk of having long-term health conditions was 3 times higher for those infected 3 times compared to those who were uninfected. And one last concern that's top of mind for many in public health is that it has been shown that high levels of viral circulation increase the likelihood of new viral mutations emerging. A new COVID variant or subvariant of concern can arise anywhere that viral transmission is high, and there's no certainty that new variants won't significantly evade vaccine protections and or cause more severe illness. We just don't know that with any certainty yet. What we've learned over the course of the pandemic is that this is a dangerous virus. We benefit enormously for all the effective tools at hand, and they allow most of us to fully live our lives. We travel, we go to work, we go to parties, we enjoy concerts, plays, and sporting events, and we get together freely with those we love. However, when transmission is really high, we would be foolish to be complacent and not layer in additional protections that help those most vulnerable also fully live their lives. Next slide. Despite all of the concerns I've discussed about the current high transmission rates of COVID, driven by the BA.5 Omicron subvariant, I do want to close on a note of encouragement. There are sensible steps we each can take and are taking to care for ourselves and to reduce the risk for others. With the proliferation of easily transmissible variants, being up to date on vaccinations offers the best chance of not experiencing the worst outcomes. Vaccines and boosters continue to significantly reduce the risk of severe disease and death from COVID should somebody become infected. If you have underlying health conditions or you're an older adult, be prepared to seek treatment right away if you become sick with COVID. There are free life-saving medications available to treat you should you become infected and sick, and you can learn more about these free medications at our website. At home and in your community, there are several steps you can take to lower risk. Get tested if you're sick or you recently were exposed, and isolate away from others if you tested positive. If your child is attending a camp or another summer program, you should test them at least once before they head off to participate. If you're planning to attend a private event, test yourself before going and stay home if you test positive. Or if you're hosting an event, it does make sense when transmission is this high to ask others to test before attending, particularly if you're gathering indoors. Outside, of course, remains safer than inside for parties and events. When you do move indoors, it's really good to increase ventilation, especially if folks did not test before gathering. It's also good to mask indoors if you're not actively eating or drinking, if there are people that are at higher risk attending your gathering. When out and about, don't wait for a masking requirement before masking indoors. This is the time, as we've been saying for weeks, to put that mask on when you go inside. If you're eating indoors and you're going to take off your mask, it is safest to choose a location that has great ventilation and some distance from others. At workplaces, there are a number of steps that can reduce risk of viral exposure. Maximizing ventilation is primary because it reduces the amount of virus in the air should an infected person be present. Daily symptom screening continues to be important, and those experiencing symptoms should stay home and get tested. If you test negative the first time and you have symptoms, you should still stay home, and we recommend testing again 24 to 48 hours later. Workplaces must provide medical grade masks and/or respirators, and they may choose to require indoor masking. Workplaces that are experiencing outbreaks have additional reporting, masking, testing, and return to work requirements. In closing, I do appreciate all that everyone is doing to stay safe and care for others. We're a wonderful county with amazing people, and we have a long history of working together to protect each other. Thanks, and I'll now answer your questions.
Thank you, Dr. Ferrer. As a reminder, if you have a question, you can chat me, the host, or you may use the hand raise icon. Our first question comes from Marla Tejas from Fox 11. Marla, you're unmuted. Go ahead.
Hello, good afternoon, Dr. Ferrer. Thank you so much for taking our questions today. Regarding the potential conflict of interest involving your daughter, we did receive a statement, as you know, from the health department last night on your behalf, but we do want to give you an opportunity now to respond. Why did you choose not to disclose your relationship on the study that your daughter co-authored? The study itself says no potential conflicts of interest were disclosed. Why did you feel it wasn't necessary to do so? And are you concerned at all about further eroding public trust? On the masking.
Let's just stop. Let me try to get to that question because you put a lot there. I am not an author. I am not an author on that study. I had nothing to do with that study. I didn't review that study. I actually didn't see that study until recently. The people who complete conflict of interest forms are the people who worked on the study, who completed those conflict of interest forms. I have no family relatives that work at the Department of Public Health. I don't supervise any family relatives who do any work that relates to work at the Department of Public Health. Have no interest or ability to control any of my family members' work, since they don't work for me or at this department at all. So there's no conflict of interest here at all. I think I'm not really sure what you're referring to, since I had nothing to do with the study. We can go to the second question. You have our statement. I didn't work on this study. There's no conflict of interest. I didn't direct any work, and I have no family members that work at the Department of Public Health and are supervised or supported by me.
Right. We know that your daughter does work for the Office of Education, which is part of this study. And you are acknowledged in the acknowledgements. Your name is on there. So that's also something of note.
I didn't work on the study, Marla. I had nothing to do with the study.
Okay, as it relates to mask
I'm acknowledged, as is Dr. Eduardo, as being heads of our departments, as sort of the work of our departments in contributing to the study. But I did not work on the study. There are no conflicts of interest. It's really, it's hard to imagine what you're finding is a possible conflict of interest, since I did not work on this study. And I want to go on to the next question, because there are lots of other people that are trying to ask questions as
Okay,
well.
then my last question, then I was going to ask about the potential mask mandate, but I'm curious though about you said that you've never looked at this study until recently, as far as reporting shows that you've leaned on the study before in terms of to form your mask policy for schools, as has the CDC director. She mentioned this specific study in one of her briefings in August of 2021.
I don't know where the reference is for me referring to this study, but happy to take a look at that. I did not review this study before it was published. We have a chief science officer who is in charge of reviewing studies here. That's not my role. I didn't see this study, and I recently looked at it in relationship to the concerns that were being raised. But I'm glad the CDC director uses studies. I'm proud of the staff here that work on really pulling together our data. I think this is data from quite a while ago that really showed that you can open schools safely if you go ahead and integrate a whole host of protection measures. So again, I'd urge people go look at the study. It really wasn't a study just on masking or the effectiveness of masking. It was a whole set of layered protections that helped at schools reduce transmission. And we're grateful for all the partnerships with the schools because in layering in those protections, schools were actually very safe places for students and staff to be. So thanks for that. We can go on to the next question.
Next question comes from Christine Maiduk from the Wall Street Journal. Christine, you're unmuted. Go ahead.
Thanks, Dr. Ferrer. So I wanted to ask about the likely, I'm assuming, return to an indoor mask mandate next Friday. Can you talk a little bit more about what enforcement would look like? And, I've been talking to experts who say really a mandate is only as good as its uptake and adherence. So would there be any real enforcement efforts by the county, especially for businesses that might openly flout an indoor mask mandate like there had been some before? I think the county had sued at least one business regarding their actions during the pandemic and whether they were open or doing indoor dining when they weren't supposed to. What kind of enforcement are you envisioning? And then the other question I have is, in speaking to public health experts as well about this approach that LA County is taking, it definitely differs from many of the other counties across the country that are in the same high transmission level. So can you explain why LA County is, taking this approach, why this approach is, you're confident this approach is the right way to handle it, whereas other counties seem to be taking a much more wait and see approach to it. I was told by one expert that mask mandates in the kind of mature stage of the pandemic have less effectiveness than they did maybe in March or April of 2020, and that it's kind of a big ask for the public.
Yeah, thanks so much. I appreciate both those questions. So, we've had mask mandates before in this county, and we really relied heavily on a lot of education and technical assistance at most sites. I think over the course of the pandemic, for everything that has been a requirement, there have been, I believe, less than 1% of businesses have received any citations. So we've worked really hard so people understand what they can do to really encourage high compliance. And that's the approach that we'll be taking should we return to universal indoor masking. That usually involves us working with all the different business sectors to make sure that they understand their obligations. We want to make sure that employees in particular have access to high filtration masks that fit well, and that employees are being notified of their need to go ahead and wear those masks whenever they're in the indoor portions of those businesses. We have noted, as we have in the past, that businesses are required to put up signage so that those coming in as customers or as visitors know that there is, in fact, a universal indoor masking at their sites. But we have always noted that we don't expect any businesses, or particularly employees at businesses, to be enforcers, and that we understand, as there has been throughout the pandemic, that there are some people who will go ahead and, as you noted, not be in compliance. We obviously hope that most people, as they have in the past, will go ahead when they're indoors at businesses that have good signage telling them, please go ahead and we want you to mask up, that they'll go ahead and put those masks on. It creates a safer work environment. Obviously, when there's this much transmission for both the workers that are there and for visitors and customers. So again, I don't think this is going to be any changes from where we've been before, which is we rely heavily on people understanding why it's important for us to add in this layer of protection at this point. And most people in the past have gone ahead and been compliant, so we'll continue to work with everyone, make sure people have good information. We also, we're very lucky. We have a partnership with PPE Unite, so that those small businesses that for whom this might be a hardship will have good access to a free supply of high quality masks for both their employees and for visitors and customers. I think it's a good segue into the second question. Why are we bothering to go in this direction when so many others are not? I think I showed you the data that drives our decisions. We feel like, unfortunately, for some people, this is still a virus that can cause a fair amount of devastation. At this point, we have tried to ask people to make their own decisions about masking and go ahead and mask so that we could slow down transmission, and that hasn't been very successful. We think many more people are likely to now go ahead and put on those masks. Getting transmission levels down low benefits everybody, but it particularly reduces risks for those most vulnerable. LA County's huge. We're over 10 million people. In those people that are unvaccinated alone in LA County are 2 million people who we all know will have a lot of increased risk. We also have a lot of folks who are older. We have lots of nursing homes here, and that means lots of residents who live in those nursing homes and are at higher risk when the rates are this high. We have many essential workers who work in manufacturing plants and factories because we are a highly industrial county where we've seen lots and lots of outbreaks in the past and easy transmission. So again, layering in protections for our most vulnerable workers, a lot of them essential workers, many of them low-wage workers, at this point seems like a sensible step. And you've all seen the data that disproportionality continues, so that those people who live in communities with higher rates of poverty, our Black and brown residents, are ending up hospitalized at higher rates, especially during surges, than other people. As a matter of fact, last week I shared data that shows that fully vaccinated residents living in communities with high rates of poverty are more likely to be hospitalized than unvaccinated residents that live in our wealthiest communities. So, we're trying to address disproportionality, add in this layer of protection. We have two hopes. One is that we start to see some significant declines and don't actually need to move forward with universal indoor masking. And the second is that if we should need to move forward, it's because it's really important for us to layer in that protection because our rates are not coming down, that many folks do so that we can just be in this high community level for a very short period of time. That would be our hope. But thanks for those questions.
Our next question comes from Ron Lynn from the LA Times. Ron, you're unmuted. Go ahead.
Hi, Dr. Ferrer. Thanks for taking our questions. We really appreciate it. First, on County USC, last week, two physicians there seemed to suggest the pandemic was no big deal, that COVID infections were essentially like bad colds, and asserting that no patients there were suffering from pulmonary disease. And one of them said there's no reason from a hospitalization due to COVID perspective to be worried at this point. I know you provided a lot of data earlier in your briefing, but can you respond directly to those assertions? Second, a crystal ball question: with case rates and hospitalization rates flattening, do you think we're probably likely to continue hitting the high COVID community level trigger next week, or do you think it's possible we'll miss it and go back to medium? And then finally, there are some people who are being very cautious, and certain industries and conventions have imposed their own mask mandates or are moving some sessions to virtual. But it's also clear that among some people, there's just a lot less fear of COVID. And part of it is the fact that they observe that many people who are infected turn out fine, and some people think that COVID won't negatively affect people like them. What would you tell them? Thank you.
Yeah, really, thanks for all those questions. Let me, I'm going to try to get to all of them. Let me start with our partners over at LAC USC at the hospital. I first want to start by thanking everybody who works there. They've done really made tremendous efforts for a very long time to keep patients well cared for, and have absolutely been our partners throughout the entire pandemic. That meeting was a town hall for staff where they were appropriately noting that at the hospital, things look very different, and that staff should be reassured that while we're all seeing these big increases in cases, because the tools we have had are effective, they are not resulting in the horrors that everyone experienced previously as cases went up. And we're in complete agreement with that. So I think in some ways, I want to make sure that we've been saying all along, we're doing so much better, so much less risk to individual people who are in fact vaccinated, boosted, getting seriously ill, and passing away. And because we have millions and millions of people that are vaccine boosted, it's making a huge difference. And so I don't think there's any disagreement that we're in a much better place. And we're in a much better place because we have a lot better tools. We also now, for the last few months, have therapeutics. And at a place like LAC USC, where they have a whole network of clinics associated with their hospitals, they're also able to provide really good outpatient care for their patients, which again, I think helps keep people out of the hospital. So I want to commend the team there for the great work that they did. I want to thank them for acknowledging, as I think some of their remarks may have been taken out of context, for acknowledging that we continue to need to layer in protections, vaccinating, testing, mask wearing. At all of our healthcare facilities, everyone wears a mask, every single person, to reduce risk. So I don't think there's any doubt on where our sister agency stands in terms of the need for there to be efforts that continue to protect those most vulnerable in our communities, and that includes layering in these protections. In terms of, the crystal ball question, I don't know for sure. I think it's highly likely we could stay in high. I will note that should we start seeing, which obviously today's numbers aren't going to support, but should we start seeing a steep decline in our numbers next week, because we know that hospitalizations are this lagging indicator, we are likely to want to, take a pause on moving too quickly on an indoor masking, a universal indoor masking, because if our cases really start a steep decline, it's likely that a couple of weeks from now, our hospitalizations will also decline. And you all are looking at the same data. You could see we're on the cusp between medium and high. It isn't going to take much to move us back into that medium community level if we can get our case numbers to go lower. And I didn't get your last question. Sorry, Ron. Can Ron be unmuted for the last question?
Yeah, I'm trying to. Hang on one second. My apologies. There we go. Ron, can you speak now?
Yeah, I was just wondering, what would be your message to people who think that COVID won't negatively affect people like them? So,
I mean, I think we've been super clear, like we're in a much better place and people should enjoy their lives. And they shouldn't worry as much. There's no need for the vast majority of people to really be worried like we were when we had no tools and we had very little information. Like we're so not there. But I also, think that we have to be realistic and not dismissive. I think we're exhausted with living through a pandemic, and it's very attractive to minimize what in fact is happening now so that we can absolutely feel comfortable paying no attention to what's going on with COVID. And I think that's a mistake. I think we have a nice middle ground that we can live in and live well in, which is when the numbers shoot really high, we layer in more protections. When our numbers are lower, we can remove some of those additional protections, but we remain vigilant because of the uncertainty associated with new variants, the uncertainty associated with long COVID, and frankly, the uncertainty with who exactly can experience some of the worst outcomes from COVID. So, for people who are vulnerable and fully vaxxed and fully boosted, they are still at risk. So again, being sensible about taking precautions so that you can enjoy your life fully, I think makes a lot of sense. And I know people are sort of saying, putting masks on is really asking a lot of folks. We asked a lot more of everybody for a much longer time, for much of the past 2 years. And I think, we're tired of this, and masks have come to symbolize, lots of other things that, we really would like to put aside. I would urge people to think of your mask as an act of kindness, respect, and consideration for others, and help us get back to slowing the spread, which is what will benefit everybody. So thanks for that.
Our next question comes from Sandra Mitchell from KTLA. Sandra, you're unmuted. Go ahead.
Yes, Dr. Ferreira, thank you for taking our questions today and for all of your insight. My question would be going back to the criticism that you did not disclose the relationship with your daughter. And I see that you're smiling and giggling.
I'm actually going to not comment. I made a comment. I think I answered the question. Unless it's a different question,
It is a different question. My question is,
you don't disclose conflicts if you're not an author on an article. Okay, so for folks who are new to the research world, everybody who is participating in authoring an article discloses. The second thing I want to note is there are many, many hundreds of instances where family members, in fact, collaborate on research projects. And you're right, they will disclose a conflict of interest. But I want to note the conflict of interest is not that they're a family member. Okay, the conflict of interest have to do with, does anybody influence what you're writing? So unless there's reporting authorities that need to get disclosed, husbands and wives, partners, children and their parents are welcomed to participate on research studies together. I did not participate in this project, so I did not disclose anything because I wasn't part of this research study at all. Had nothing to do with it.
so you don't believe that the public had the right to know to maintain your credibility with the public?
No, I don't. I think the public knows what they need to know. I don't supervise any family members. I have no influence on the work that any of my family members does. I had nothing to do with the folks that worked on that research project. I applaud them for the work that they did. It was a collaboration between two different departments that work together. So yes, I mean, you're actually insinuating that if I have a family member that works at RAND or UCLA and researchers here and researchers at a different business or firm collaborate, that I would be disclosing that even if I had absolutely nothing to do with the project. And you can see on the face of it there's no conflict of interest here. So I want to put that to rest. I think you can go off on, spinning that in a different way, but I'm not sure where there's any conflicts there. And I do want to move on because I think there are lots of other very important questions that people may want to ask me.
Thanks, Dr. Freer. Our next question comes from Howard Bloom from the LA Times. Howard, you're unmuted. Go ahead.
Hi, thanks for taking my question. I appreciate it. Under mandatory, I have two questions. The first one is pretty easy, I think. Under mandatory masking at schools, does the school have to provide if we get there, does the school have to provide masks as needed to students as well as employees? That would be one question. And to what extent have schools moved away from PCR testing, universal testing, and periodic sampling, and instead are relying on antigen testing using a response?
Yeah, thanks. I'm not sure I can answer fully the second one, like in terms of quantifying it, but we can get that information to you, Howard. In terms of the first question, schools are not required to go ahead and provide their students with masks by the health department. Most schools, as you know, in the past have, in fact, for students who come without masks, have been very easily able to provide those masks. And we have also, are always available for folks who need to figure out how to secure a supply of masks. There is a requirement for masks to be provided to employees. So I think that's different, but there's no requirement by health officer order for students. In terms of the antigen testing, you're right to note that many districts, although not all, have moved from PCR testing to antigen testing. And some of them have moved, there's two ways you can do that antigen testing. You can set up a system at your school with the CLIA-Wave tests where they're actually administered. They're antigen tests, you get a rapid result, but it's administered by staff at the school, or you can use those over-the-counter test kits that you may send home. We're working with all of the school districts right now. We want to, first of all, make sure that whatever system they're putting in place has that capacity that you noted to do response testing, because there are requirements, there are Cal OSHA requirements around response testing for staff, and we want to make sure that there's capacity to do response testing when there are cases and outbreaks at schools. So we work really hard to make sure that school districts have all of the support they need to go ahead and have that capacity. As we are seeing now, there may be, and some districts may make these decisions, no requirements on this. There may be places where school districts may choose to continue with what we call routine testing. That's, school districts that ask everybody to test. Some districts were doing it once a week. Everybody was testing. Others were doing it once every couple of weeks or once every 3 weeks. And again, we'll be supporting schools. There's no requirement for that routine testing. Obviously, when transmission rates are very high, testing allows you to identify those asymptomatic people pretty quickly and have them go back home and not pass along infection in your school environment. When transmission gets low, there's really much less need for that routine testing. Our hope is that as schools start reopening in the middle and later part of August, that we do reduce transmission in the community, because we know that'll be helpful at schools. So thank you.
Dr. Freer, any closing remarks?
No, thanks a lot. I was going to say I need to go. So, sorry. Thanks a lot, everyone. Appreciate all of the questions always. If we didn't get to your question, please go ahead and send it in to us. We're always happy to respond in writing, and appreciate your willingness to share with your viewers and your listeners updated information always. So thank you.
Thank you, Dr. Freer, and thank you to everyone who joined us today. As Dr. Freer stated, additional media questions can be sent to our media inbox at media@ph.lacounty.gov. If you stick around, we'll do Spanish remarks in about 5 minutes. Thanks. Hi, Deanna, can you hear me?
Hi, Kim. I can hear you.
Perfect. Deanna, are you ready to begin?
Yes, I'm ready. Buenas tardes y gracias por acompañarnos durante esta sesión informativa. Hoy daremos un informe sobre el estado de COVID-19 para el condado de Los Ángeles y compartiré información sobre la importancia de reducir la velocidad de transmisión. First slide, please. Vamos a empezar con un reporte. Los casos, las hospitalizaciones y la positividad de las pruebas siguen elevados. El día de hoy estamos reportando 8,691 casos nuevos, con el número promedio de casos reportados durante la última semana, superando los 6,700 casos nuevos por día. Si bien los números de hoy son muy altos, queremos asegurar que los casos reportados la semana pasada se han anivelado. Estamos observando esto de cerca para ver si esta tendencia continúa. Como recordatorio, todos los números de casos están subestimados, ya que no incluyen los resultados positivos de las pruebas de venta libre. La tasa promedio de positividad de la prueba de 7 días sigue siendo alto, alrededor del 16%. En todo el estado, la tasa de positividad también es del 16% y a nivel nacional es del 17,5%. En el condado de Los Ángeles también está pasando por un aumento continuo en la cantidad de pacientes con COVID en los 92 hospitales del condado de Los Ángeles. Hubo 1,202 el jueves pasado y hoy contamos con 1,329. Entre los hospitalizados con COVID, alrededor del 42% tienen enfermedades asociadas con COVID. El 11% están en una unidad de cuidados intensivos o ICU por sus siglas en inglés y el 5% están conectados a ventiladores para poder respirar. Repasaremos los datos de hospitalizaciones con más detalle en un par de minutos. Quiero mencionar que los fallecimientos se mantuvieron estables la semana pasada con un promedio de 13 muertes reportadas por día. Como recordatorio, dado que las muertes siempre van a la saga de los casos y las hospitalizaciones, la ralentización de la transmisión viral dará lugar a tasas más bajas de hospitalización y mortalidad en unas semanas. Next slide, please. Vamos a estar observando los datos desde marzo y podremos ver los aumentos a partir de fines de abril y mayo en ingresos hospitalarios y casos, el aumento mucho menor en muertes. Es probable que los aumentos más recientes se deban a la transmisión de la subvariante BA5 que esquiva el sistema inmunitario. El promedio de 7 días de casos reportados al diario representaron aquí con una línea verde, ha sido muy alto, más alto que durante el aumento de Delta de hace un año. Como mencioné anteriormente, hay una señal de que los casos se estancaron la semana pasada y esperamos que esto continúe. Sin embargo, es importante tener en cuenta que en las últimas 2 meses hemos visto estos pequeñas disminuciones que fueron seguidas por incrementos adicionales, por lo que tiene sentido que debemos seguir siendo cautelosos dada la cantidad de casos tan alta. La admisión hospitalaria diaria que vamos a ver aquí en una línea anaranjada también puede estar estabilizándose un poco. Veremos más detalle en las próximas diapositivas. Las muertes diarias que podrán ver aquí con una línea azul aumentaron durante el último mes con un promedio de 5 muertes diarias hace un mes y un promedio de 13 muertes diarias esta semana. Nuestros pensamientos y deseos de paz están con las familias y sus amistades que están de luto. Next slide, please. A lo largo de la pandemia, las personas infectadas con el virus han sentido diferentes síntomas y niveles de gravedad en su enfermedad, desde infecciones completamente asintomáticas hasta enfermedades graves, y lo más trágico es el tener que enfrentar la muerte. Con el tiempo, hemos visto un cambio en la cantidad de personas infectadas que requieren cuidados en nuestros hospitales y luego fallecen. Esto se debe en gran parte a las protecciones que ofrece la vacuna y las infecciones previas y por medio de tratamientos efectivos. El impacto del virus ha estado cambiando y la gravedad de la enfermedad se ha calculado por el porcentaje de personas con un resultado positivo en la prueba que requiere hospitalización y observación de las tasas hospitalarias a largo tiempo. Dado que ahora es menos probable que las personas infectadas requieran atención hospitalaria, es importante separar de nuestras cifras a las personas en el hospital con infecciones incidentales, o sea, aquellas personas que necesitan atención hospitalaria por razones distintas al tratamiento de COVID, pero también están infectadas con el COVID, y de las que están en el hospital porque necesitan atención por una enfermedad directamente relacionada con COVID. Por lo que desde hace unos meses venimos reportando el número de hospitalizaciones incidentales. Aunque estos casos ejercen una presión adicional en los hospitales, debido a que cualquier persona infectada con COVID requiera que el hospital tome medidas de seguridad adicionales, es poco probable que estas hospitalizaciones reflejen pacientes con enfermedades graves relacionadas con COVID. Hoy vamos a compartir algunas cifras que representan información sobre aquellos pacientes donde se determinó que tenían una enfermedad asociada con COVID. Esto incluye a pacientes que en el momento de darles de alta tuvieron lo siguiente: una prueba positiva, neumonía, dificultad respiratoria aguda, o un diagnóstico cardiopulmonar agudo. En esta gráfica podemos ver qué porcentaje de casos hospitalarios tuvieron enfermedades asociadas con COVID cada mes a partir de enero de este año. La línea dorada muestra el porcentaje de las personas hospitalizadas infectadas con COVID. La línea azul muestra el porcentaje de admisiones a urgencias, ICU por sus siglas en inglés, y la línea roja muestra el porcentaje de personas que fueron intubadas. Como puede ver, desde enero, el porcentaje de pacientes con COVID que estuvo hospitalizado con enfermedades asociadas a COVID ha disminuido del 58% en enero durante la oleada del aumento invernal al 23% en junio. Sin embargo, esto entre los pacientes infectados que necesitaron atención en urgencias, el porcentaje se ha mantenido más estable, 85% en enero y 71% en junio. Finalmente, entre los pacientes infectados que fueron intubados, la gran mayoría fueron pacientes con enfermedades asociadas al COVID. el 92% en enero y un bajón leve al 86% en junio. Las próximas gráficas van a mostrar los datos de hospitalización para aquellos hospitalizados por enfermedades asociadas con COVID. Next slide, please. COVID ha afectado de manera desproporcionada a unas comunidades más que a otras. Una comunidad particularmente afectada son los residentes mayores. En esta gráfica observamos a los hospitalizados con enfermedades asociadas a COVID en diferentes grupos de edades desde marzo hasta junio de este año. Una nota que debe tener en cuenta es que los datos en esta diapositiva se limitan solo a la primera hospitalización asociada al COVID por caso, por lo que es probable que estas tasas sean una representación insuficiente de las tasas reales. Como se anticipó, las personas de 80 años o más han sido hospitalizadas con enfermedades asociadas al COVID a una tasa más alta que otros grupos de edades durante la pandemia. Lamentablemente, con tasas de transmisión muy altas, las tasas de hospitalización han aumentado drásticamente para los adultos mayores. Al 30 de junio, la tasa de ingresos hospitalarios con enfermedades asociadas al COVID para personas de 80 años en adelante fue 29 veces más elevada que para las personas de 30 a 49 años. Esto contrasta destacadamente con la diferencia en las tasas de admisión en el mes de abril, cuando la diferencia entre las tasas de ingreso no fue tan grande. Cuando la gente transmite información errónea de que el aumento actual de COVID no está afectando ni perjudicando a nadie, estas son las personas a las que se están lastimando, a nuestros seres queridos de la tercera edad. Esto se debe a que COVID sigue siendo más alarmante para aquellos que tienen más probabilidades de sufrir una enfermedad grave si se infectan. Next slide, please. Aquí veremos que las comunidades afroamericanas y latinas han sido afectadas desproporcionadamente durante la pandemia y de manera similar a lo que reportamos anteriormente cuando repasamos las tasas de hospitalización para personas con enfermedades asociadas con COVID por raza o etnicidad desde marzo hasta fines de junio. A partir de abril, la tasa de hospitalización para los residentes afroamericanos aumentó y fue más pronunciada que para todos los demás grupos raciales. A partir del 30 de junio, la tasa de hospitalización de los residentes negros fue 3.3 veces mayor que la de los residentes asiáticos y 1.8 veces mayor que la de los residentes blancos. Y recientemente hemos comenzado a tener aumentos más pronunciados entre los residentes latines. Next slide, please. Como reportamos anteriormente, los residentes que viven en comunidades con ingresos más bajos también tienen más probabilidades de ser hospitalizados que los que viven en comunidades adineradas. Y si bien las personas en las áreas de mayor pobreza han tenido tasas de hospitalización más altas que las personas que viven en áreas más ricas, la brecha ha aumentado recientemente. A medida de que agravó el aumento actual a fines de junio, las personas en comunidades con mayor pobreza tienen 2 veces más probabilidades de ser hospitalizadas por COVID que las personas que viven en áreas con menos pobreza. Además, las tasas de hospitalización por COVID están aumentando más rápidamente en las comunidades que viven en pobreza en las comunidades, comparado con las comunidades más ricas. Las tasas de hospitalización para las comunidades de ingresos más bajos aumentaron el 350% veces más en 2 meses en comparación con un aumento del 178% en las comunidades de ingresos más altos durante el mismo periodo de tiempo. Si bien hay muchos factores que contribuyen a la desproporcionalidad observada por la raza, etnicidad, la pobreza en la área. Los aumentos repentinos en los casos perjudican severamente a los más vulnerables debido al aumento de la exposición, al estado de salud subyacente, a su edad, al acceso a recursos que afirman la salud. Si nos preocupamos por eliminar estas brechas, debemos reducir las tasas de transmisión durante los picos que hemos visto una y otra vez perjudican a algunos residentes más que a otros. Next slide, please. Y bueno, seguimos investigando el impacto de la pandemia en el condado de Los Ángeles utilizando el marco de niveles comunitario COVID-19 de los CDC, una manera de medir la presión y el estrés dentro de nuestro sistema de atención médica causada por COVID-19. El marco de niveles comunitarios utiliza una métrica de tasa de casos y 2 métricas de hospitalización. La semana pasada, el condado de Los Ángeles pasó de nivel comunitario COVID a medio a alto y permanecemos en alto esta semana. La primera métrica en nuestra tasa de casos de 7 días ha subido a 481 casos por semana por cada 100,000 personas. Esta es la tasa más alta desde que los CDC comenzaron a usar el marco de niveles comunitarios a principios de marzo del 2022. La primera de las 2 métricas hospitalarias es el total de 7 días de nuevas admisiones hospitalarias por cada 100,000 personas. El condado de Los Ángeles tiene 11.4 admisiones por cada 100,000 habitantes. La segunda métrica hospitalaria en el marco de niveles comunitarios de los CDC es el promedio de los 7 días para la proporción de camas en hospitales siendo ocupadas por pacientes con COVID-19. Actualmente, el 7.1 de las camas están ocupadas por pacientes con COVID en el condado de Los Ángeles. Tengan en cuenta que este número se ve afectado tanto por la cantidad de pacientes con COVID en los hospitales como por la cantidad de camas con personal en el hospital. Tener personal enfermo debido a COVID y otras razones pueden causar que la cantidad de camas con personal disponibles en un hospital disminuya temporalmente, lo que también afecta a esta métrica. Como mencioné en informes anteriores, si permanecemos en el nivel comunitario alto durante 2 semanas consecutivas, es decir, hasta el 28 de julio, implementaremos el uso de mascarillas universal en interiores el 29 de julio para ayudar a reducir la tasa de transmisión y proteger a los más vulnerables. De todas las herramientas que hemos utilizado durante la pandemia para neutralizar la propagación de COVID, el uso de tapabocas al entrar a cualquier lugar es una de las herramientas más simples y efectivas que tenemos para frenar la propagación de este virus. Next slide, please. Nuestras señales de alerta temprana también continúan indicando un mayor riesgo en el condado. Como verán, el aumento actual está brindando dificultades en los sitios de trabajo y provocando brotes entre los más vulnerables, especialmente en nuestros hogares para personas de la tercera edad. Actualmente, con excepción a una de las métricas de alerta temprana, estamos viendo que miden a medio o a alta. Tenemos preocupaciones altas en 4 señales. El porcentaje de variantes nuevas, especialmente con la subvariante BA4 y BA5, que representan el 72% de las muestras. La tasa de casos de 7 días en áreas con mayor pobreza aumentó en la última semana de 272 a 351 por cada 100,000 personas. La cantidad de brotes en centros de cuidado especializado y la cantidad de grupos de casos en lugares de trabajo en una semana aumentó de 371 a 429. Las visitas al departamento de emergencias relacionado con el COVID sigue siendo de preocupación media, habiendo aumentado el 10% y la cantidad de brotes en entornos para personas sin hogar también sigue siendo de preocupación media. Y aunque ninguno de nuestros 4 sistemas de agua residuales pasó por una duplicación reciente en carga viral, aún reflejan un nivel de transmisión viral alto. Ahora pasaremos varias señales. Vamos a ver las señales con más detalle en las próximas gráficas. Next slide, please. La variante Omicron sigue representando el 100% de las muestras secuenciadas. Las subvariantes BA5, BA4 también de Omicron, como podrán ver en rojo en la parte superior de cada barra, continúan siendo de mayor preocupación porque ambas tienen la capacidad de evadir la inmunidad previa, por lo tanto reinfectan a las personas que ya fueron infectadas con otras subvariantes. En la semana que finalizó el 2 de julio, BA4 y BA5 representaron el 72% de todas las muestras secuenciadas, lo que representa un aumento del 82% en comparación con las 2 semanas anteriores. La BA5 es la variante dominante que representa el 57.6% de todas las muestras secuenciadas en comparación con la BA2.12.1. De nuevo, la BA2.12.1 solo representó el 23.5% de muestras secuenciadas. Los CDCs estimaron que en todo el país, a partir de la semana que terminó el 16 de julio, la subvariante BA5 representó el 78% de las muestras, un impulso del 55% observado 2 semanas antes. Tengan en cuenta que el nuevo sublinaje de Omicron, llamado BA2.75, se ha estado propagando principalmente en la India y que también tiene la capacidad de reinfectar. La cifra ha aumentado ligeramente la semana pasada en los Estados Unidos. Esperamos que no surja. Al momento se han detectado 12 casos en los Estados Unidos, 5 de ellos en California y con un caso en el condado de Los Ángeles. Seguiremos monitoreando este sublinaje. Las habilidades de estas variantes nuevas, como la BA4 y la BA5, de causar reinfecciones y evadir ciertas inmunidades previas, están impulsando la propagación más rápidamente, resultando en numerosos brotes y el aumento de hospitalizaciones. Sin embargo, todos sabemos cómo mitigar la transmisión de cualquier variante de COVID para reducir la amenaza hacia la salud de todos, especialmente a los más vulnerables. La acción colectiva sigue siendo muy importante, como recomienda la OMS y los CDC y la Casa Blanca. El ponerse la mascarilla al entrar a cualquier lugar por parte de todos durante momentos cuando hay tanta transmisión es una estrategia sensata para nuestro bien. Next slide, please. Esa fue la gráfica de la que hablé hace un momento. Next slide, please. Aquí veremos los datos de las aguas residuales. Esto incluye la planta de Hyperion, que sirve una gran área de la ciudad de Los Ángeles y se muestra en la parte superior izquierda. También estamos viendo la planta conjunta de control de la contaminación de agua, que sirve partes del sur y el este del condado y se muestra en la parte superior derecha. Tenemos también la planta de Lancaster, que sirve las áreas de Lancaster y Palmdale, y está a la parte inferior izquierda, y la planta Tapia, que sirve a Calabazas y a sus alrededores, que se muestra en la parte inferior derecha. Para cada planta, la línea de tendencia blanca muestra el promedio móvil de 10 días de concentración viral entre fines de mayo y mediados de julio de este año. Comparamos tendencias entre plantas de tratamiento de aguas residuales y no cifras absolutas de carga viral, porque la forma en la que se mide la carga viral es diferente en las plantas de aguas residuales. Podrán ver que para los cuatro sistemas han habido un aumento en las cargas virales. Es posible que estemos viendo un estancamiento o incluso una ligera disminución en las plantas que sirven a las partes occidentales del condado, mientras que los aumentos pueden continuar en las plantas que sirven a Lancaster y partes del sureste del condado. Ninguna de las plantas tuvo una duplicación de carga viral en las últimas 2 semanas. Next slide, please. Lo que estamos viendo aquí es los que viven en asilos y aquellos que se encuentran sin vivienda siguen siendo impactados drásticamente. La línea morada que pueden ver aquí muestra la tendencia de brotes en centros de cuidado especializado. Y la línea verde muestra la tendencia en entornos para personas sin techo desde abril. La línea amarilla muestra el umbral que pasa de preocupación baja a media y la línea amarilla discontinuada superior muestra el umbral entre preocupación media y alta. Desde principios de mayo, el número semanal de brotes en centros de cuidado especializado ha señalado frecuentemente una preocupación alta y continúa haciéndolo ahora con 33 brotes la semana pasada. Los brotes en entornos de personas sin vivienda también aumentaron durante el mismo periodo de tiempo, manteniéndose en el nivel de preocupación media durante la mayoría de las semanas desde mediados de mayo, aunque como se puede ver en esta diapositiva, hubo 19 brotes en la semana pasada, que es un aumento en las últimas 2 semanas. Los centros de enfermería especializada continúan brindando protecciones mejoradas a los residentes y a su personal para prevenir brotes. Sin embargo, cuando permitimos que la transmisión comunitaria continúe alta, esto pues va a afectar y va a poner a riesgo a los más vulnerables y se va a ver aquí. Next slide, please. Los sitios de trabajo siguen siendo lugar a donde se suele propagar el virus durante los tiempos de transmisión elevada. En esta gráfica verán una línea rosa que muestra la tendencia de la cantidad de grupos de casos en los sitios de trabajo reportados por semana desde principios de abril. Ha habido un aumento continuo con 429 en la última semana, un aumento del 47% en el último mes, lo que indica una preocupación elevada durante varias semanas desde principios de julio. Los trabajadores infectados transmiten el virus en su lugar de trabajo a otros trabajadores, quienes llevan las infecciones a sus hogares. Y ahí puede haber aún más propagación, lo que facilita que el virus se propague por toda la comunidad. Next slide, please. En este punto de la pandemia, no es raro escuchar comentarios que minimizan nuestros niveles de transmisión. Sin embargo, dada la incertidumbre de la trayectoria de esta pandemia, nos gustaría hablar sobre el por qué vale la pena tomar medidas prácticas y de sentido común para frenar esta transmisión. Primero, cuando la transmisión viral es tan alta, como señalamos anteriormente, hay muchos inconvenientes e interrupciones en sitios de trabajo y en nuestros hogares. Si bien algunos sufren una enfermedad leve, muchos no, y vemos esto en la duplicación de casos a urgencias por COVID en los últimos 2 meses. También vemos esto en la escasez de personal en sitios de trabajo, incluso en nuestros mismos centros de salud. Los brotes en los lugares de trabajo son costosos, ya que hay un costo asociado con la cobertura de turnos y la prevención de una propagación mayor. Los hogares con personas infectadas también sufren obstáculos. Para algunos esto incluye salarios perdidos, dificultades para aislarse y la necesidad de buscar ayuda para el cuidado de los niños. La transmisión comunitaria alta también brinda muertes prevenibles y evitables, principalmente entre los más vulnerables. Casi 4.500 personas han muerto, 4.500 por COVID este año. Si podemos frenar la transmisión, lo deberíamos hacer. Tenemos la posibilidad de evitar que más personas mueran en los próximos meses. Es decir, si no nos infectamos, no nos enfermamos y pues no morimos, ¿verdad? También hay algunas cuestiones que deberían preocuparnos. Para empezar, si bien todavía se necesita información adicional, está claro que muchas personas infectadas con COVID han pasado por COVID prolongado y con grandes aumentos en casos. Es probable que más personas reporten síntomas de enfermedades semanas después de la infección inicial. Si los síntomas más comunes que estamos viendo con el COVID prolongado son fatiga, intolerancia al movimiento, al ejercicio. Sin embargo, algunos han presentado problemas respiratorios, desórdenes mentales, pérdida prolongada del gusto, el olfato e incluso pérdida repentina del cabello. Si los síntomas más comunes de COVID prolongado son fatiga e intolerancia, pues son cosas que tenemos que notar, ¿verdad? Estos síntomas son variables y pueden prolongar o pueden reaparecer con el tiempo. Esto hace que sea más difícil rastrear y estudiar sistemáticamente al COVID prolongado por eso es que las estimaciones sobre cuántos sufren este COVID prolongado son muy variables. Lo que sí sabemos es que un metaanálisis publicado recientemente de estudios del 2020 y 2021 estimaron que en promedio alrededor del mundo como unos 37% de las personas con COVID todavía tenían algunos síntomas un mes después. Un estudio también realizado por investigadores en USC, publicado este mes, encontró que el 23% de los que estudiaron todavía tenían algún síntoma o síntomas 12 semanas después de que comenzaron y que el COVID prolongado parecía más probable en aquellos con obesidad o que habían sentido dolor de garganta, dolor de cabeza, pérdida de cabello durante el inicio de su enfermedad. Otro estudio publicado este año por investigadores alemanes dio seguimiento a 96 casos de personas con COVID en el 2020 y encontró que un año después solo el 23% estaba totalmente libre de síntomas. Y una encuesta realizada por los CDC el mes pasado estimó que casi el 20% de los adultos estadounidenses que han tenido COVID-19 actualmente sienten síntomas prolongados de COVID y que han durado 3 o más meses después de enfermarse. Estos estudios y estos detalles pintan una imagen del impacto a largo plazo de COVID y ayudan a explicar el por qué debemos ser honestos y tener en cuenta que para un número alto de personas, esta pandemia sigue representando una amenaza muy real. Next slide, please. Y bueno, también hay un estudio reciente que ha planteado una preocupación adicional sobre los mayores riesgos a la salud creados por infecciones repetidas. Ya que la BA5 puede evadir la inmunidad previa, muchas personas que tuvieron COVID antes de la pandemia o incluso a principios de este año se están infectando nuevamente. Este estudio fue uno a donde se grabaron los registros médicos de 300,000 veteranos con COVID que abarcan gran parte del 2020 y 2021. La mayoría de las personas en este estudio fueron hombres blancos de edad promedia de 60 años. El estudio encontró que a los 6 meses después de la infección, aquellos que habían sido infectados más de una vez tenían un riesgo 2 veces mayor de muerte, un riesgo 3 veces mayor de necesitar atención hospitalaria y un riesgo 2.5 veces mayor de desarrollar enfermedades cardíacas, pulmonares o problemas con los vasos sanguíneos, la coagulación de la sangre en comparación con los infectados solo una vez. También notamos que aquellos con infecciones repetidas tuvieron un mayor riesgo de pasar por trastornos gastrointestinales, renales, problemas de salud mental, dolores musculares, dolores en los huesos y síntomas neurológicos y diabetes. Además, el riesgo de desarrollar un problema de salud a largo plazo aumentó, aunque aún más con cada reinfección. El riesgo de tener una condición de salud a largo plazo fue 3 veces más para los infectados en comparación con los que no se infectaron. Y una última preocupación que es lo primordial para muchos en salud pública, es que se ha demostrado que los altos niveles de circulación viral aumentan la probabilidad de que surjan nuevas evoluciones virales. Puede surgir una variante o subvariante nueva de COVID en cualquier lugar donde la transmisión viral sea alta y no hay certeza de que las variantes nuevas no evadan drásticamente las protecciones de las vacunas y o causen una enfermedad más grave. Lo que hemos aprendido a lo largo de la pandemia es que este es un virus muy peligroso. Nos beneficiamos tanto de las herramientas que tenemos a la mano y que la mayoría de nosotros nos estamos viviendo vidas plenas, aún así, ¿verdad? Viajamos, vamos a fiestas, disfrutamos de conciertos, obras de teatro, eventos deportivos y convivimos con nuestros seres queridos. Sin embargo, cuando la transmisión es realmente alta, sería un error gravísimo ser complacientes y no agregar protecciones adicionales que ayuden a los más vulnerables a vivir sus vidas de la mejor manera y que la vivan plenamente también. Next slide, please. A pesar de todas las preocupaciones que hemos discutido sobre la alta transmisión de COVID, nos gustaría terminar con una nota de aliento. Hay pasos sensatos que cada uno puede tomar para cuidarse a sí mismo y reducir el riesgo para los demás. Con la propagación de variantes altamente transmisibles, estar al día con las vacunas ofrece la mejor oportunidad de no pasar por lo peor. Las vacunas y los refuerzos continúan reduciendo el riesgo de enfermedad grave y muerte por COVID en caso de que se infecte. Si tiene problemas de salud subyacentes o es un adulto mayor, estar preparado y buscar tratamiento de inmediato si se enferma de COVID es muy importante. Hay medicamentos gratuitos que salvan vidas y son disponibles en caso de que se infecte o se enferme. Puede obtener más información aquí en la página de salud pública. Puede ver los enlaces en la pantalla para el enlace directo. En casa y en la comunidad hay varios pasos que puede tomar para reducir el riesgo. Se puede hacer la prueba si está enfermo o si estuvo expuesto recientemente y se puede aislar de los demás si da positivo. Si su hijo asiste a un programa de verano o a un campamento, hágale la prueba al menos una vez antes de que participe. Si planea asistir a un evento privado, hágase la prueba antes de ir y quédese en casa si no se siente bien o sale positivo. Y si está organizado un evento, puede pedirle a todos que se hagan la prueba antes de asistir. Afuera sigue siendo más seguro que estar adentro durante fiestas y eventos. Y si llega a entrar a algún sitio durante algún sitio, pues aumente la ventilación y especialmente si la gente no se hizo la prueba antes de reunirse, es sensato usar una mascarilla cuando no está comiendo o bebiendo, especialmente si alguien con problemas de salud está presente. Cuando esté fuera de casa, no espere un requisito de uso de cubrebocas para tomar precauciones. Si está comiendo adentro, pues puede estar un poco más segura eligiendo un lugar con buena ventilación y una distancia sana de los demás. En lugares de trabajo hay una serie de pasos que pueden reducir el riesgo de exposición viral. La ventilación es primordial, ya que reduce la cantidad de virus en el aire en caso de que haya una persona infectada presente. La evaluación diaria de síntomas sigue siendo importante y aquellos que tengan síntomas deben quedarse en casa y hacerse la prueba. Los sitios de trabajo deben proporcionar mascarillas y o respiradores de grado médico y pueden optar por exigir mascarillas al estar adentro. Los lugares de trabajo que tienen brotes deben seguir medidas requeridas que incluyen el hacer reportes, el enmascaramiento, las pruebas y el regreso al trabajo con precauciones. Y bueno, para cerrar, apreciamos todo lo que están haciendo para mantenerse a salvo y a cuidar a los demás. Somos un condado maravilloso, con gente increíble y tenemos una larga historia de luchar juntos para protegernos el uno al otro. Que tengan bonita tarde y hasta pronto.
I want to thank everyone for attending. You may send additional questions to our media inbox at media@ph.lacounty.gov. Thank you.